Okay, so good morning. Thank you, Dr. Gleaf and Dr. McNeely, for the introduction. We're going to start with our topic, buccal mucosa graft in reconstructive urethral surgery. The objectives, we're going to talk about the history and the evolution of the use of the oral mucosa in reconstructive urethral surgery and the techniques for harvesting. We're going to talk about the biological and the structural characteristics of the oral mucosa graft for reconstructive urethral surgery. And we're also going to present the long-term outcomes in the use of the buccal mucosa for primary and revisional hypospadias in our institution. So tissue transfer is a fundamental technique in reconstructive surgery, and choosing which tissue to use as a substitution material actually depends on the properties of the tissue and the recipient area. For years, reconstructive urologists have pursued the answer to which tissue is the best suited to be transferred into the urinary tract. And for the past 3 decades, the oral mucosa has been considered to be the ideal tissue. The oral graft can be harvested from the buccal, the labial, or the lingual mucosa, of course, being the buccal mucosa the most frequently used. It is ideal because it can tolerate the wet environment, therefore befitting the urinary tract. It is a highly resilient tissue. It acts as a major barrier to infections. And once it is transferred and exposed to urine, it has the ability to thrive. So it is imperative for urologists to become familiar with its intrinsic properties, techniques for harvesting, complications of harvesting, and of course, the various applications. Going back in history, oral mucosa has been used as a free graft for over a century. The fields of ophthalmology and oral and maxillofacial surgery were the first to apply oral mucosa graft as a substitute material for various facial and oral defects. In urology, it was not until the late 20th century that oral mucosa graft actually became widely accepted as a suitable replacement for urethral mucosa. So in the late 19th century, the first surgeon credited with using the oral mucosa for urethral substitution is Dr. Kirill Sapensko. He's a professor at the University of Kyiv in Ukraine, and he performed a series of 4 urethral mucosa graft urethroplasty. In his case, he used the lift and the buccal mucosa graft, and he also used a 2-stage urethroplasty and a 1-stage urethroplasty. He reported that 3 out of the 4 urethroplasties were successful. Despite his pioneering work, it was not until the turn of the 20th century that Dr. Sapensko actually gained recognition for his accomplishments. Then, in 1941, Dr. Graham Humby published a case report in an 8-year-old boy with hypospadias for which he performed the urethroplasty by tubularizing the labial graft over a catheter, as that picture that we have, and then he anastomized it to the hypospadic urethra. Then in 1990s, Dr. Berger from Germany and Dr. Di Santi from Italy published a small series of using buccal mucosa graft for complex urethroplasty and hypospadias repairs in pediatric populations. Their results had few postoperative complications, such as fistulas, needle stenosis, but in overall, the results were promising. Then in 1993, Dr. El Kasavi from Egypt reported a 90% success rate from the treatment of short penile and bulbar strictures in 20 adult patients. And finally, in 1995 in USA, Dr. Basking and Duquette described the favorable histological properties of the buccal mucosa as a graft material, and they reported encouraging clinical results in hypospadias urethroplasties. And Dr. McAnish, who described different surgical approaches, both of whom I had the honor to work with when I was in UCSF. The intrinsic properties of buccal mucosa enables it to be a favorable material for transplantation. So histologically, it has a thick and non-keratinized stratified squamous cell epithelium, similar to the penile and glandular urethra. Its thickness is directly associated with male gender and indirectly associated with age. It can successfully withstand the rigorous shearing forces due to its elasticity and the components of the lamina propria. The epithelium layer overlies a thin but very highly vascular lamina propria. In contrast, other materials used in urethral reconstruction, such as the bladder mucosa on the penile skin, have a thin epithelium but a very thick lamina propria. And the properties of the lamina propria facilitate graft take, as the thinness of it enables imbibition and its dense plexus of blood vessels promote enosculation. So you're going to ask me, hey, What's imbibition and inosculation? So the ultimate outcome of any grafting procedure depends on revascularization, which is the development of new blood vessels or blood supply, and the take, meaning that the graft tissue undergoes neovascularization after excision and transfer to a graft host bed. Then the take occurs in two phases. Together, they require approximately 96 hours. During the initial phase, called imbibition, approximately occurs 24 to 48 hours after. The graft temperature is lower than the core body temperature, and the graft survives by taking up nutrients from all the adjacent graft host bed. During the second phase, termed inosculation, that approximately happens 48 hours after, the graft temperature rises to the core body temperature, and then the true microcirculation is reestablished within the graft. The process of take is influenced both by the nature of the graft and the conditions of the graft host bed. This is a very nice paper by Sof. They prospectively evaluated 22 patients with recurrent urethral strictures after a buccal mucosa. Intraoperatively, they harvested a sample of the freshly harvested buccal graft from the cheek. That's figure 1, the figure 8. We see that it is composed of a thick sheet of non-keratinized squamous epithelium, delined as number 1, and a thin lamina propria, marked as the large arrow. Then in figure B is the harvested bulbar urethra consisting of a thin pseudostratified urothelium. And figure D shows that the integrated buccal mucosa that had been transplanted previously preserved the histological characteristics of the oral mucosa, and it is not overgrown with urothelium. So the arrow shows the urothelium demarcation. So the authors conclude that buccal mucosa graft keeps its histological characteristics without undergoing the metaplasia or epithelial thinning that other grafts can present. So they compare. The CIS graft, it's being replaced by columnar epithelium and smooth muscle cells. The preputial flap decreases the number of cell layers, and the tunica vaginalis having the mesothelium lining replaced by stratified epithelium, similar to the native urothelium. So how do we harvest the oral mucosa? It is important to understand its anatomy and, of course, our goals. The oral mucosa graft can be harvested from the cheek, from the lower lip, or from the tongue. If we harvest from the cheek, we have to know what that's a common site. We always have to be aware of the parotid duct or the Stenson stud, which travels across the masseter muscle, then the buccal fat pad, and then the buccinator muscle. Its draining orifice is located adjacent to the maxillary second molar. So once we've identified it, an elliptical or a rectangular graft is drawn from the axis extending from the oral commissure anteriorly to the external oblique reach at the mandible posteriorly. Once we've done that, we can inject 1% of lidocaine with epinephrine to infiltrate into the submucosal plane and use it as a hydrodissection. This picture, courtesy of Dr. Jaime Perez, illustrates step-by-step the process of harvesting and graft defatting. We start by having a good exposure, therefore coordinate with anesthesia the intubation techniques. We use a good mouth retractor, whatever we feel comfortable with. Once the dissection plane is created, above the submucosal adipose layer, it is important to be aware to leave intact the buccinator muscle in order to prevent complications. Then, the graft is thinned by draping it over the non-index finger and tangentially cutting away all the muscle fibers, the excess fat, and submucosa with a sharp curved irises. Now, be aware not to take a lot of fat off. Let's compare the different sites. Harvesting techniques is easier for the lower lip and the tongue when compared to the cheek. The cheek and the tongue provides you with 2 grafts, and the lower lip with 1 graft. Sizes are variable. From the cheek, you can harvest a 6 times 2 centimeter graft versus a 4 times 1.5 centimeter from the lip, and then 16 times 2.5 centimeters from the tongue. To be honest, I have never harvested a graft from the tongue. The cheek has better histological features, being more robust and thick, plus it gives you the option to leave the donor site open with minor morbidity. So this leads me to this article by Wood and colleagues. They concluded that the morbidity of the buccal mucosa graft harvested is relatively minor and occurs in less than 30% of the cases. The main long-term complications are numbness of the oral cavity, persistent difficulty with mouth opening and changes in salivatory function. And patients need to be advised that this is not a pain-free procedure, that pain appears to be worse after the cheek is sutured, and it may be just best to just leave it open. This other paper, published in 2019, included 269 patients from 4 randomized controlled trials. So the overall pooled effect estimates on pain score assessed on postoperative day 1, day 3 and 7, and 6 months had no significant difference between the closure and the non-closure treatment groups. A subgroup analysis showed that rectangular-shaped buccal mucosa grafts have less pain when they're left open on postoperative day 1. Then perioral numbness, pulled from 2 studies that was the ones who reported it, show significantly lower mouth opening impairment in the non-closure group at postoperative day 1, but had no difference between the groups beyond this point. And finally, there was no difference regarding bleeding or long-term complications regarding further interventions. Now let's compare again the sites with respect to their morbidity. Postoperative pain is very common for all the sites. Site contracture is common for the cheek and the lower lip. Sensory defects, persistent numbness, and aesthetic changes are common when harvesting from the lower lip. Whether we close that defect or not, it is much as a surgeon preference, but the data suggest to leave it open. The first 2 pictures, courtesy of Dr. McNeely, and the last one, courtesy of Dr. Perez again. These are the results when the donor site is left open, the first one, and it is healed by second intention. The second image, sutured up. And then the final result, whether you close it or you leave it open, is exactly the same. You cannot even differentiate which was which. Once the graft is ready, we proceed with a stage substitution urethroplasty, which involves excising the stricture and the abnormal urethra, fenestrating the graft, then quilting the strip of the graft into the corpora cavernosa, and having a proximal urethrostomy diverting urine or a suprapubic tube, as indicated in the last picture. The graft is then dressed for the initial postoperative period, and then it's left open for it to heal for the second stage. After the graft heals, which typically takes 6 to 12 months, it is then mobilized from the skin edges to allow tubularization of the neurourethra over a catheter. When patients are giving information about a stage procedure, they must be warned that the second stage can be carried out only and only if the results of the first stage are adequate. Surgical procedures of substitution urethroplasty are categorized into one-stage surgeries and stage procedures. And the appropriate procedures for each stricture depends on the stricture location, the number, the width of the urethral lumen, the degree of spongiofibrosis, and the etiology. There are 3 potential options for a one-stage procedure, whether we do the Inlay augmentation procedure, or we do an augmented anastomotic procedure, and finally, a tube augmentation. Now, one-stage tube augmentation have a high risk of stricture recurrence, regardless the stricture location, and we should avoid this one. In the developed world, more than 90% of the urethral strictures are in the anterior urethra, and approximately half of them occur in the bulbar urethra. Most bulbar strictures not amenable to excision and primary anastomosis can be reconstructed by one-stage ventral or dorsal inlay augmentations. When a bulbar urethral stricture has an obliterated segment, one solution would be an augmented anastomotic urethroplasty or the Palminteri technique. For a penile stricture, we have the option to do a staged technique or an Asopa technique. We have to be careful that if we have to excise the urethral segment or we are dealing with a failed hypospadias or lichen sclerosing, we always have to do a staged urethroplasty. So the ventral onlay was initially described by Mori and Dr. McAnish from UCSF. It involves a perineal incision. It follows with a midline incision over the bulbum spongiosum, as you see in the diagram. Once the stricture is located, a midline sagittal incision is made through the ventral spongiosum, and then the graft is sewn directly to the edges of the urethrotomy. The outer adventitia, you can see in these lower diagrams, then the outer adventitia of the corpora spongiosum is closed over the graft. The advantages include minimal dissection, robust blood supply in the ventral sponge, easier for proximal exposure. Disadvantages include more blood loss, less structural support, and less intraoperative adaptability. The results, more than 88% of success in the literature. Now the dorsal onlay, which was described by Barbagli and colleagues, it is carried out through a perineal incision again. The bulbous spongiosum muscle is divided and circumferentially isolated. We isolate the bulbar urethra. Then a dorsal urethrotomy is made through the stricture urethra, and the buccal graft is sutured to the underlying tunica albuginea to the corpora cavernosa. Its advantages is that it has less blood loss, intraoperative adaptability, more surrounding support tissue around it. And then the disadvantages includes disruption of the surrounding microvascular environment, challenging visualization for sure, and the dissection very close to the membranous sphincter. Results, promising. More than 88% success rate in the literature with Manguera and Chappell in 2014. Then the dorsal inlay, which was described by Asopa and colleagues. Following the ventral urethrotomy with a concurrent dorsal urethrotomy, subsequently we split the dorsal urethra and dissect it free from the underlying corpora cavernosa. Then the graft is quilted into the isolated tunica and secured laterally to the urethrotomy mucosal edges. Then the overlying ventral urethrotomy is closed, whether we do it in 1 or 2 layers, that's per surgeon preference. And the advantages include minimal dissection, preservation of the native microvascular network, easier for proximal exposure, and more surrounding support. However, it reduces the size of the graft due to its fixation. It also requires more than 1 urethrotomy and has more blood loss. Results, Asopa have results of more than 87% success rates. And finally, the Palminteri technique, which involves a dorsal inlay and a ventral onlay. But its disadvantages includes less surrounding structural support of the ventral graft. It increases the demand of graft material. It has more than 1 urethrotomy and more blood loss. Success rates, almost 90%. Hypospadias is the second most common congenital anomaly, affecting 1 in every 200 and 300 male newborns. The majority of the hypospadias are usually distal, and since the late 90s, the treatment has been with tubularized incised plate urethroplasty, also known as Snodgrass procedure. However, in boys with a small or a flat glans or a shallow glandular cleft, incising the urethral plate may not allow us to have an effective tubularization. And to address this problem, we need to place a graft in the defect that we have created by incising the urethral plate. So a buccal mucosa graft or an inner perpusal skin is commonly employed in this procedure, and this is known as a dorsal inlay graft urethroplasty. More than 300 surgical procedures have been described for hypospadias repair, suggesting that no single approach is fully satisfactory for all variants. Many studies have documented a significant rate for reoperation after the primary procedure, and failed hypospadias occurs when the primary surgery does not achieve the cosmetic nor the functional goals of a straight penis with a glandular meatus that enables normal urination and sexual function. It is worth noting here that none of the repairs available to date can actually create a urethra with the same biological and urodynamic properties as the native one. So hypospadias repair have long-term complications. And this study, published in 2013 in Belgium, included more than 400 patients with a mean follow-up of 34 months. They documented that 24% of these patients required a reoperation. And from these, almost 40% of them required a reoperation after more than 2 years of follow-up. So yes, it is important to follow these patients lifelong. Possible complications after a hypospadias repair includes meatal stenosis up to 14% and urethral strictures up to 12%, both requiring interventions with meatotomies, urethral dilations, or even redo urethroplasties. Glans dehiscence in 8%, which can be observed in can be just followed up or observed, or we can redo the distal urethroplasty. Fistulas in 28%, we treat them with a simple primary closure or a closure with a flap. Diverticulums up to 12%, usually requiring substitution urethroplasty. Cordes up to 32%, they can require a substitution urethroplasty, a corporoplasty, or even just observation. A bad cosmesis in 55%, which will require a free skin graft, skin expanders, and skin reconfiguration. And interesting, this article does not report breakdown, but we will give this prevalence after analyzing our own patients. So we conducted a retrospective study. Our objective is to report the long-term outcomes of buccal mucosa graft for failed hypospadias, knowing that this is challenging due to the local tissue scarring and the lack of adjacent healthy tissue. So we reviewed the charts of all 51 patients who underwent buccal mucosa graft to repair hypospadias between January 2004 to December 2021. In some patients with severe penile curvature, some corrective procedures took place prior to grafting. So this table summarizes the patient characteristics. We have a median age of 6 years of age. Follow-up in time was 5 years with a range of 1 to 15 years. The majority of our patients had initially a penile-scrotal hypospadias with 70.6%. The number of prior procedures was 2.7, that's the median, and the standard deviation 2. And the indication for a buccal mucosa graft was, for the majority of our patients, fistula in 29%, and the severity or preputial graft contracture in 25.5%. Of course, we also had patients that presented with strictures, urethral breakdowns. Some presented with hair, that's in 4 patients. And there was 1 patient which we decided to do the buccal graft since the beginning. The interval time between the stages was 9 months, ranging from 6 months to even 83 months of interval. The coverage, when we do the second stage, was the majority of the patients. The second layer was done with dartos at 47.7%, and followed by tunica vaginalis in 33%. This other category that you see that says other involves skin antiseal, or involves the mixture of dartos and tunica vaginalis. Now, urinary diversion with suprapubic tube for the second stage was used in 72% of the patients, and 64% of the patients had the site of the harvest closed. So table 2 summarizes the complications in the first and in the second stage. In the first stage, we had no complications in 80% of the patients, in 41 patients. Then we have in 17% a graft contraction. And for this, we did a redo buccal. 4 of them underwent transfer island flap onlays, and 1 had an SIS. And 1 had epididymitis, which we just treated with antibiotics. For the second stage, 31% of the patients had no complications. 24% of our patients presented with a fistula, any location. 2% urinary tract infection, 17% presented urethral breakdown, and 17% stricture. 4%, that's 2 patients, hair in the graft, and diverticulum was seen in 1 patient who is currently being observed. So what's the final status of our patients today? We have a success rate of 56%. 4% of them are pending closure of those redos buccals. 14% are pending a redo of the entire reconstruction. That means starting all over again. And 26% have a fistula or a stricture. From these 26%, most of them we are just observing until they reach puberty in order to have higher success rates when closing the fistulas, or the strictures, some of those are just having endoscopic dilations. The relationship between some anatomical and surgical factors and the subsequent complications was investigated using a cross table. So the initial severity had a likelihood ratio of 19 with a p-value that was significant. That means the more severe the hypospadias, that most likely that I will have a complication. The number of prior surgeries, likelihood ratio of 7.1, but a p-value not significant. Does the coverage, whether we do it with dartos, tunica, skin, tissue, whatever it comes to your mind, does it have any impact? The p-value not significant with 0.8. Now, does having a urinary diversion for the second stage prevent complications? We have an odds ratio of 1.6, a confidence interval of 1.2 to 2.068. We cannot really determine the significance of having a suprapubic tube, but we can observe that in all our patients, those who had the suprapubic tube had less complications. Those who didn't, they all failed, or they all had a complication. So what does the literature say? This is a unique study by Barbagli and colleagues. It includes 408 adults that presented urethral stricture after having primary hypospadias repair. Their median follow-up was 96 months, and the mean age was 35 years of age. The majority of the patients had penile hypospadias. The multivariable analysis revealed that the number of previous operations needed for the initial hypospadias repair was not associated with the risk of treatment failure. That's with a hazard ratio of 0.9. And the length of stenosis and the lichen sclerosis both were associated with a higher risk of treatment failure. The length of stenosis with a hazard ratio of 1.88 with a significant p-value, and lichen sclerosis with a hazard ratio of 1.73 with a significant p-value. The majority of the patients that had a balanic hypospadias presented frequently with a meatal stenosis in 80%. The penile and penoscrotal hypospadias both had penile strictures more often, with 68% for penile hypospadias and 60% for penoscrotal hypospadias. The penoscrotal hypospadias also presented panurethral strictures with 30% of the cohort. And interestingly, they had 8% of bulbar stenosis, regardless the hypospadia site. And in our study, we actually have 1 patient that also had bulbar stenosis. The usual treatment for the complications included meatotomy or meataloplasty in 20%, 1-stage repair, but 2-stage repair being more often in 37%, periosteotomy in 7% of the patients, internal urethrotomies in 2%, and fistula closures in 5%. This other study, published recently, also evaluated the long-term outcomes with patients using buccal versus inner perpusal skin graft in the primary and redo hypospadias. So table 1 highlights the number of types of complications experienced in both primary and revisional surgeries. For primary repairs with either buccal mucosa graft or inner perpusal skin graft, 32% of the patients experienced a complication. All reoperative repairs were performed with the buccal mucosa graft, and they experienced a lower complication rate with 22%. Urethrocutaneous fistulas, 16%, and meatal stenosis, 8%, were the two most common complications observed in primary repairs. On the other hand, gland separation with 22% was observed most commonly in the revision surgeries. Complications were recognized at an average of 23 months after the primary repair and 0.5 months after the revisional surgery. Table 2 now shows all the 28 inner propucial skin grafts that were used for primary repairs. Of these repairs, 21% of the patients experienced complications, the most common being ureterocutaneous fistula with 11%, compared to a 42% complications in the cohort of buccal mucosa graft. The inferior results of the buccal mucosa graft in primary compared to reoperative repairs really was unexpected and currently without an obvious explanation. This other study by Dr. Kim and colleagues, this was published in 2020, its univariate regression analysis revealed that lower H at surgery, that a small size urethral catheter used for the buccal mucosa graft tubularization, that means 8 French, and multiple operations prior to the buccal mucosa graft were associated with a higher likelihood of postoperative urethral stricture. But on the multivariate analysis controlling for H, for size of urethral catheter, and for the number of previous operations, the multiple previous operations had a significant p-value with 0.007, and a small size of urethral catheter, a p-value of 0.046. And we confirmed that these are confirmed to be significant factors associated with postoperative urethral strictures. Now, there is a lot of heterogeneity in the data, and it is really difficult to us to understand why some patients failed. This is an example of how two different authors, one from UK and one from Canada, have different complication rates for the same procedure. Braca reports a 7% complication rate, while Leslie and colleagues report a 34% complication rate, much similar to our results, huh? So why do hypospadias repair fail? Why does a buccal mucosa graft contract? Is it because there's a suboptimal graft intake? Is it exposure to air while harvesting a factor? Is a defatting and compromising the adventitial layer another factor? What about the poor vascularity of the wound bed? Is the air exposure during surgery have any impact? Is there any infection happening? Is there any effect on scarring and compromised vascularity when it comes to the uptake of the graft? And finally, the individual biological variation. Why some patients healed perfectly with a flexible scar, and then another patient with the same scar heals with a hypertrophic scar or even a keloid formation. Future research should be focused on tissue engineering technology by developing graft material that can be used for long strictures with extensive spongiofibrosis or for those that have poorly vascular beds. Now, tissue-engineered buccal mucosa and urethral mucosa substitutes are promising alternatives, but require a longer-term and larger cohort clinical trials before being advocated for a widespread use. Other researchers have focused their time with a cellular human bladder matrix with SIS grafts and collagen gel seeds with oral cells. However, there exists great variability between the studies. Very fast, this table summarizes all the different studies involved in tissue-engineered graft, but there are small studies with different surgical techniques, different follow-up, and different definition of success. We're still not in that future, but one day we may have options for those severe cases in which an oral mucosa graft may not be suitable. Finally, a take-home message. Buccal mucosa grafts are widely available. They're easy to harvest. They adapt to the urinary tract. In reconstructive urethral surgery, they have modest results. They can be reproducible, but they do need experience to limit the complication rates. So thank you for your time. It would be a pleasure now to answer some questions.